Thank you, Haley, for the introduction. What we wanted to talk about this afternoon are the status of telehealth policy at the federal level. Since the end of 2024, we have been in a really sort of back and forth on the edge of our seats, waiting to understand what the new administration, what CMS will be doing with certain telehealth policies that we've really become accustomed to throughout and after the COVID 19 public health emergency. So, what I wanted to talk about was sort of revisiting what the pre COVID 19 Medicare telehealth rules were. It's hard to remember 5 years ago what those restrictions were, but I think they're really important because we're at a really pivotal time in telehealth policy where, in just a few months, certain policies could very likely be reverting to some of those pre COVID 19 telehealth rules. And what I wanted to focus on today is a little bit of a refresher on what rules surrounding the coverage of telehealth under the Medicare program live under Congress's purview that take a literal act of Congress to change, to extend, to modify, versus what is within CMS's purview to dictate through policy and through rulemaking, kind of where we stand today on both pathways. We're also going to go through some important dates coming up in the next several months that to be watching. And of course, we'll keep you updated through updates at Heartland Telehealth Resource Center if any late breaking news comes out surrounding federal packages that affect telehealth. So I want to rewind just a little bit. And at the end of 2024, we had some uncertainty surrounding what telehealth policy was going to look like on January 1. What we had was the 2025 Medicare final rule for the physician fee schedule. And that's where a lot of the telehealth policy year to year that's created by CMS lives. And in that fee schedule, CMS addressed some telehealth policy, but not everything. And there were some provisions that they cannot address because it's really outside of their purview. It takes a literal act of Congress. And at the end of 2024, we were waiting for a financial bill, a financial package to come out from Congress. And in the last several years since the public health emergency ended, it has been that financial package each year that has extended some of the telehealth waivers that we have been operating under since the public health emergency have been extended through these financial packages. So I want to go through just really quickly a reminder of what Congress controls versus what is under CMS's purview. So, what takes a literal act of Congress with respect to telehealth rules and coverage for the Medicare program ties back to when an originating site fee will be paid or will not be paid. Under the Social Security Act and the rules where telehealth policy live, typically CMS does not pay an originating site fee if the patient is at home. And there had been some flexibilities to that during the public health emergency, but it is Congress and statutes, not CMS policy, that will dictate whether we continue to have that flexibility to bill an originating site fee, the place where the patient is located at the time of a telehealth service. The list of eligible originating sites, so the location where the patient is at the time of a telehealth service, that's also dictated by Congress and by federal law. It is not something that CMS has much flexibility to modify in the absence of a public health emergency. So, under the Social Security Act, where the rules surrounding the eligible originating sites, where the patient's located at the time of a telehealth service, there's a geographical restriction. Typically, prior to the public health emergency, the patient had to be geographically located in a rural area, which was outside of a metropolitan statistical area, or alternatively, a healthcare provider shortage area, which was really restrictive for urban, suburban areas that wouldn't meet that geographic requirement, regardless of the healthcare setting where the patient was presenting. Two pieces had to be met, both that geographical area, but also the type of setting the patient presented to. It needed to be a physician office. A critical access hospital could be an eligible originating site. Rural health clinics, FQHCs, have always been eligible originating sites where the patient's located. Regular prospective payment system hospitals, skilled nursing facilities, and community mental health centers. I have an asterisk next to home because the patient's home has been an eligible originating site even prior to the public health emergency, but it was extremely limited situations, not like the way we use the patient's home as an originating site today. It was involved for things like certain substance use disorder services and certain end-stage renal disease services, but that was about it. Um, the requirement to have an in-person visit before beginning mental behavioral telehealth services in the absence of co-occurring substance use disorder. That in-person visit requirement, that is also something that Congress dictates. It's in the Social Security Act statutes, not something CMS gets to change through policy alone. But then there are certain pieces of telehealth rules and requirements that are within CMS's purview to adopt and to modify over time through policy making without requiring Congress to act and enact or modify laws. So, unlike originating sites, the location where the patient is located, CMS has the ability to define the eligible distant site billers of telehealth services. So that's our physicians, those are our nurse practitioners or physician assistants who are delivering the telehealth service wherever the patient is located. So they're kind of dialing in from the distant site. CMS also has discretion to decide what qualifies as interactive telecommunication technology. That's the phrase, interactive telecommunication technology. That's the term used in the statutes, but it's not defined by Congress in terms of whether that's audio only, audio visual, fax, portal messages. CMS really gets to dictate what it means to be an interactive telecommunication technology. And prior to the public health emergency, CMS by and large defined that term as live, two-way, real time communications that had an audio and a visual component. And then we saw certain pieces and certain flexibilities open up for audio only telecommunications to qualify as interactive telecommunication technology. At the end of the public health emergency, we've sort of scaled back the types or the circumstances, rather, when audio only can be used as a covered telehealth service for Medicare. And CMS also gets to decide on an annual basis what services, what codes meet criteria to be covered and paid as eligible telehealth services for the Medicare program. And they don't need Congress to enact rules surrounding that list of eligible telehealth codes. So I want to look at where we were at the end of 2024 in terms of CMS policy and rulemaking, the things that were within CMS's control. Last summer, actually about this time last year, CMS had proposed to make audio only permanently available as the interactive telecommunication technology, but did not end up finalizing that proposal. Instead, they sort of came to an in between. They didn't get rid of audio only format entirely, but would allow audio only to continue with some caveats. Audio only format can be used when you're still today, can be used to deliver telehealth services to a patient covered by the Medicare program if the service is being furnished to a patient in their home and the patient's home has continued to be an eligible originating site. We're going to talk about that in a little bit because that rule lives with Congress, not with CMS. So if the Medicare patient is at home, audio only telehealth can be used if the distant site provider has the capability to join via audio, but the patient cannot or does not consent to the use of video. Then you may have an audio only visit. And there are modifiers to identify when the telehealth service has been delivered in an audio only format. Modifier 93, unless you are an RHC or an FQHC, and you use modifier FQ for those circumstances. So you see on this slide, we've talked a few times about different dates and potential for telehealth policy expiring. Our first important date was December 31st. We had the potential for a lot of the telehealth flexibilities that lived under Congress's scope and federal law to expire. And there were proposals surrounding telehealth policy right up until the second week of December that would have extended a lot of those flexibilities, like the patient's home as an eligible originating site, like waiving the rural geographic area or healthcare provider shortage area requirements that would have extended that for 2 more years. But at the last minute, about a week before the end of the year, the financial package changed and only extended those flexibilities for 90 days. So that was the end of March of 2025. So the first quarter of the year came and went, and just a few days before that potential expiration of those telehealth flexibilities, we got another extension. So, as of right now, those flexibilities for the patient to be at home, for the geographic area requirements to be waived, they've been extended through September 30th of 2025. So we're just kind of on constant pins and needles right now, kind of waiting to see the direction that Congress and the administration will be taking when it comes to telehealth policy. So I want to go back to the definition of originating site so we can see kind of what is on the table for September 30th and what kind of policies we're going to be looking for and what changes might happen. And I'm rewinding 5 years. The pre-public COVID-19 public health emergency rule was only those sites that are listed in the Social Security Act under federal law can be an eligible originating site the patient must present to in a rural geographic area or a healthcare professional shortage area to be covered telehealth under the Medicare program. So if I come up here, let me get my little laser pointer here. If I come up here to no facility fee will be paid if the patient is in their home, right? That's been an exception during the public health emergency that has been extended. That's something that is on the table to go away at the end of September 2025. And the patient must present only to certain eligible originating sites. So here's all of our originating sites, but I want to come down to how Critical Access Hospital has always been a place where the patient can present and receive a telehealth service. But what was sort of the flexibility during the public health emergency was allowing critical access hospitals to also be the distant site provider, like if their patient was at home and they could deliver a telehealth service. RHCs, FQHCs, they've always been eligible originating sites where the patient can present and receive a telehealth service. Down to the bottom, the home of the individual. That was there prior to the public health emergency, but it was for very, very limited situations, not like what we use it for today. Those limited situations, let me go back a slide where I'm referencing paragraph 7 down here, just walking you through some crosswalks in the federal law. But paragraph 7, patient being at home, was really limited to treatment of substance use disorder or co occurring mental and behavioral health conditions co occurring with a substance use disorder. And in that circumstance, the patient could be at home and deliver and receive a telehealth service covered under the Medicare program even prior to the public health emergency. During the PHE, and these are some of the flexibilities that were extended and have the possibility to continue, to be modified, or to completely expire September 30th, 2025, with respect to coverage under the Medicare program. The patient's home has been made an eligible originating site, even beyond those substance use disorder services. And in fact, the language that CMS has added says anywhere the patient is located. That might be home, it might be the parking lot of the grocery store, anywhere the patient is located in the United States could be an eligible originating site. That could go away September 30th, 2025. And again, there was a proposal that would have extended this for 2 years, but as the administration changed at the end of 2024, or at least after the elections, when we knew what the new administration would look like into 2025, Congress then significantly scaled those extensions back for a 90-day period. Really, I think so. The new administration could examine what their position was going to be on telehealth, how it might be affecting spending, and how they were going to deal with that into the new 2025 and beyond budgets. So, the patient's home as an eligible originating site could go away September 30th. It would still be an option for telehealth delivered to a patient with substance use disorder or mental behavioral conditions that co occur with substance use disorder. That would remain in effect. But for all other purposes, the patient's home as an eligible originating site could go away entirely. Congress could refine the circumstances when the patient's home could be an eligible originating site and could modify it to something completely different than what we have as our rules in effect today. The rural geographic area, I kind of use that term very loosely. The technical definition for a rural geographic area are areas outside of a metropolitan statistical area or within healthcare provider shortage areas. But collectively, I kind of shorthand that as a rural geographic area requirement. We have been able to deliver telehealth services to patients covered by Medicare to any geographic location, any place in the United States where the patient is located during the public health emergency. And that has continued afterwards each year through federal financial packages, through federal legislation. It's on the table in whatever financial package gets finalized and whatever that impact that has on telehealth policy, but without specific action to extend, to make permanent, or to modify that in some way, then October 1, we will be reverting back to patients with Medicare being required to be in a rural geographic area, a place that's located outside of a metropolitan statistical area from the census, or a healthcare provider shortage area. Now, I labeled this provisions that are influenced by congressional action, but CMS has the purview to decide who can bill as a distant site provider of telehealth services. Before the PHE, it was a pretty limited subset of professional disciplines: physicians, nurse practitioners, PAs, midwives, nurse specialists, psychology, and certain dietitians or nutrition professionals. What you see omitted from that list pre PHE were physical therapy, speech therapy, occupational therapy, critical access hospitals, FQHCs, RHCs. They were eligible to host the patient, and a distant site professional kind of zoom in and deliver a telehealth service. They were not eligible to be the distant site provider and deliver and bill for a telehealth service. And I say that it's influenced by congressional action because after the public health emergency ended, several financial packages over the last several years, 2024. Wait, yes, it ended in 23. So, financial package for the calendar year 2024 extended by legislative mandate, said physical therapists, occupational therapists, speech language pathologists, RHCs, FQHCs, they will be eligible distant site providers for telehealth services. Even though typically that's not something that's dictated by Congress, that forced CMS then to make those healthcare provider types eligible distant site providers. But what has remained within CMS's scope and purview is deciding what services can be billed, the list of eligible telehealth services. And because of that, we have PTs, OTs, speech language pathologists, technically able to bill, but if they don't have any services on the list of covered telehealth that are within their scope of practice, they essentially can be handcuffed in a way in whether they can deliver telehealth at all. Right now, all providers who are eligible to bill Medicare for professional services can provide distant site telehealth through September 30th, 2025. And that's a mandate that's available from CMS. Now, critical access hospitals, they were left off of Congress's list when the public health emergency ended, and they had been eligible distant site providers of telehealth. Congress didn't mandate that they remain eligible distant site providers. The day the public health emergency ended, they were no longer mandated by Congress. So CMS got to dictate that policy. So CMS's policy saying anyone who can bill professional services can continue to bill as distant site professionals has allowed critical access hospitals that flexibility even after the public health emergency ended. So it's really kind of goes back to a matter of who gets to decide through legislation or through policy some of these provisions. So, I want to share with you an experience I had just a couple of weeks ago. I had a chance to head to DC to talk to members of Congress and kind of advocate for certain policies that are on the horizon. And the financial reconciliation process, this bill that has been extended after the end of 2024 to March and now to September, that is the hot topic in Washington. And what gets passed or made a part of that bill really drives what will happen with telehealth on October 1 and afterwards. But what I observed in those discussions, Telehealth, in particular, was not a significant topic of discussion in the financial package. Just conversations with Congress. Really, first and foremost, there was advocacy to protect really essential Medicaid benefits and make sure there weren't cuts to Medicaid benefits and to the Medicaid program. It was really sort of a messaging of preservation of Medicare and Medicaid as it is, and telehealth, as a component of that, really wasn't a major part of the conversation. What I anticipate we may see October 1 of 2025, whatever happens in this financial package, and telehealth will either need to be part of that or its own separate legislation so that there is no gap or expiration of policy on October 1. I think we're going to see it scaled back from the direction that it had been heading, where we were seeing extensions to policy, we were seeing new coverage possibilities, we were seeing more leniency towards audio only services. The energy feels like that's being scaled back from a program integrity perspective, unless and until administration really gets a good handle and a good sense on how it's impacting spending, because fraud, waste, abuse, expenses, those were kind of the buzzwords that we're hearing from a policy perspective. So let's look at a couple of important upcoming dates. July is always an important date that we keep in mind, and I'm sure we'll be having some announcements on scheduling as soon as the proposed Medicare physician fee schedule is released. We're really going to see kind of the direction that the agency is taking with respect to telehealth policy. And we have that July date for the proposed rules, which of course can change between being proposed and being finalized. Then we have October 1 is a really important date from a federal legislative perspective, because it's October 1 where it's kind of do or die for some of these telehealth policies that we had available during the public health emergency. Will they expire completely? Will they be extended? Will they be modified? October 1 is the date where we're going to see what happens. And I don't anticipate it's going to be much advance notice prior to October when we really know what's going to happen. As I said, in December, when we were facing the first kind of expiration date prior to an extension, we learned about 10 days ahead of time that there would be an extension. In March, we learned just a few weeks ahead of time that there would be another extension to September. So I think we're going to be down to the wire like that heading into the fall, to see what Congress will do with rural geographic limitations, with originating sites, and some of those telehealth policy. Then, typically early November each year, we get the final Medicare physician fee schedule. And I anticipate it could look very different than the proposed rule we see in July because of the October 1 deadline to have either extensions or changes to sort of federal telehealth policy. And whatever Congress decides to do with some of that telehealth policy may then drive and influence what CMS as an agency does with their final rule going into 2026. And then anything that gets finalized by CMS in terms of telehealth policy would then take effect or continue in effect January 1 of 2026. So I want to highlight some of the things we often see in the proposed rule that we want to be keeping our eyes and ears open for when this comes out. Um, well, initially, there was a little bit of hesitation as to whether we would even see proposed rules for the annual fee schedule changes any longer. Back at the beginning of 2025, there were right around the time of the administration change. You may have seen in the headlines that the Department of Health and Human Services, where CMS falls under, the agency falls under that department. Health and Human Services has operated under a department wide policy that they try to do proposed rulemaking, even in circumstances that it may not be required to under federal law, under the Administrative Procedures Act. It was just their policy to do that. And when the new secretary for the Department of Health and Human Services was announced under the new administration, the secretary rescinded that policy. And there was a lot of kind of red flags going up or concern and alarm. What did that mean? It did not say that Health and Human Services or CMS would not use proposed rules any longer. It just said, as a department, they were no longer mandating throughout their department that proposed rules be used. What we've seen so far this year since then, we have a proposed rule for the hospital inpatient prospective payment system. So I anticipate we will also likely see a proposed Medicare physician fee schedule rule. And I think that's really going to illuminate what we can expect in terms of the direction for telehealth policy. I think that's going to give us some kind of guardrails or point us in the direction that Congress will likely be taking. Because CMS as an agency falls under the executive branch. And so they're trying to carry out the directive, the policy, and the direction of the president and the administration. So, what we see in that proposed rule, I think, will clue us into what the administration is thinking in terms of long term telehealth policy. I do think we're going to also see some evolving payment policy for FQHCs and RHCs that we have seen incrementally evolving over the last few years when it comes to providing and billing and receiving payment for care management services, which are not true telehealth services. They have their own benefit category for FQHCs and RHCs, but I always kind of talk about them in these sessions because they're non face to face. They're not in person with the patient. And so that I think they fall well into the overall a broader definition of telehealth maybe than the way CMS defines it. And over the last several years, the the list of services that FQHCs and RHCs can provide and bill and separately receive payment for outside of their PPS or their all inclusive rates, the care management services, that list has grown. And then in the same time frame, the way that they bill for them and the methodology to receive payment has evolved. It has evolved from a single dollar amount that was sort of an average of the payment for all care management services to a weighted payment. FQHCs and RHCs, if they tend to provide a higher volume of the more complex and the higher reimbursing care management services, CMS looked at that data globally and created a weighted average that affected the payment that FQHCs and RHCs get for those care management services. And then for this year, policy evolved even further so that FQHCs, RHCs no longer reported a narrow list of G codes, HCPCS codes for care management, but instead we're expected to start billing each individual CPT code describing care management services or HCPCS codes and would receive the physician fee schedule rate for the actual service being rendered. I expect we're going to see more policy like that continuing to evolve the way FQHCs and RHCs bill and receive payment under care management. I also anticipate in July, we're going to get a better direction on CMS's position for audio only services. And right now, it's considerably scaled back from what it had been during the public health emergency, where a lot of services that were on the list of covered telehealth for the Medicare program could be delivered as audio only. For this year, even though CMS proposed to continue that very broad use of audio only, they significantly scaled it back and scaled it back so that it's limited to the patient being at home, the patient being incapable of or not consenting to using video, but the provider has the capability to join via video if the patient wanted to do so. Only when those criteria are met can audio only be used as the format for interactive telecommunication technology this year. I anticipate, just kind of given the nature of telehealth policy and the direction we've seen over the last 6 months, that it probably audio only as a format for telehealth, at least under the Medicare program, is likely to remain scaled back, kind of in the format that we've got for this year. I don't expect, could be surprised, I don't expect we're going to see it broaden further, at least this year, while the administration seems to be really focused on getting a handle on spending and reining that in before they kind of examine broadening policies for the future. And before we open it for questions, I also wanted to point out that there is a pretty new CMS Medicare Learning Network bulletin. And when we send the materials out, this will have the hyperlink if you click up here on the title. But it was just updated in April. And I think this is interesting because the text that you see in red, this was just one out of 11 pages, but a little screenshot that I think kind of is also illuminating maybe where the administration their policy or their position on telehealth is, and potentially what we might see October 1. So in red, they're highlighting that starting October 1, the statutory limits that were in place before COVID will retake effect. Geographic restrictions, the originating sites, the locations where the patient can be located for a distant site professional to render telehealth services, and then reverting back on the scope of professionals who can provide telehealth services. This bottom one, that's within CMS's scope to define and decide, and it looks like they're planning to revert that to a little bit more restrictive list of services. Now, this could be they put the policy, this text into the Medicare Learning Network publication because technically this is accurate, absent some act of Congress. This is what's going to happen, or they could be signaling what they think is likely as an agency and sort of the direction of where they think telehealth policy is headed under the administration. Okay, I'm going to pause there and Haley, open it up to see if we have any questions in the chat that I can help answer.
Yeah, definitely. So we did have one come in. The question was, if the origination site changes back to the pre-pandemic requirement, would the patient simply need to attest to their location, or how would we otherwise know where the patient was located?
Yeah, that's a great question. And I think one of the answers is that most of the locations, let me see if I can turn my camera back on now that I don't have screen sharing. Most of those locations within the Social Security Act, they are healthcare settings. And so typically you are going to have both the distance site fee and you're going to have an originating site fee that's billed by the provider office, the FQHC, the RHC, or the hospital. So one indication might be that you don't have a corresponding originating site fee. There's also the place of service that is used. I'm trying to think back. Last year or the year before, I kind of lose track of time, a new telehealth place of service code was created. 02 had been the place of service code used really for the years prior to identify a telehealth service, and it caused the payment rate for the service to be reduced to a lower facility rate of payment, with the idea that the originating site billing an originating site fee is getting the kind of practice expense or overhead portion of that. There's a new place of service code 10 that is used for telehealth for patients who are at home. So that's going to be one indication if the patient is at home, not at one of those eligible originating sites. You would not be able to use place of service 2. It would have to be a 10. And then from the billing perspective, CMS is going to look and see, is this one of those substance use disorder or mental behavioral health conditions co occurring with substance use disorder that is eligible to bill and be paid for a patient who's at home?
Great. Thank you so much. It looks like we do have another one. So just to confirm, any service listed on Medicare's telehealth list can be performed audio only as long as Medicare's audio only definition is met. Just wondering if that's correct. So for example, can they perform a Medicare AWV audio only?
That's a great question. And before I answer it definitively, I want to pull up that list of eligible telehealth services. The format that CMS has published it in over the last couple of years seems to kind of change year to year. A year or two ago, they had a really nice format where they had a list of the codes. Certain ones could be delivered in an audio only format, and they had a nice little like yes or an X indicator on a column that said audio only. Then they removed that column and they put it back, and I cannot remember the format that they put it in this year. So let me double check that, and then Haley, we could send that out to clarify. I'll look at the annual wellness visit in particular to see if it's on the list, but there may still be a limitation on the list of covered telehealth services for eligibility to use audio only to begin with, and then only if these criteria are met.
Perfect. Well, yeah, we'll definitely include that. We can get it in the follow-up email as well. It looks like one other question that we had was from an RHC perspective on the modifier for audio only. Do they only use the FQ, or do they use both the the 93 and FQ? Or is it 93 for everyone besides RHCs and FQHCs?
That's a good question. Let me triple check that. My recollection is that FQHCs and RHCs will use the FQ modifier, and they do not also have to use 93. They could, but they do not have to. 93 was for non FQHCs, non RHCs delivering telehealth in an audio only format. But I will triple check what the final rule said this year for FQHCs and RHCs.
Okay, perfect. Thank you so much. It looks like we do have a number of other questions coming in. It looks like they're also wondering where we could get more information about the distance site fee.
So the distance site fees, those are the E&M or the HCPCS codes describing the type of telehealth service that's being rendered, like an office visit, an annual wellness visit, a hospital visit. So I can get the link, Haley, that we can send out with the materials. And I saw a question pop up about the slides when we send the slides out also. And I can give that link where you can find it for 2025. In the Medicare final rule that's released, there's a ton of attachments that go with it every year. One of those attachments is the list of covered telehealth services, and that's referring to the CPT or the HCPCS codes that CMS will allow to be provided as telehealth services. And so that's what you're going to be looking for from the distance site perspective on what you code and bill. The originating site is easy. It's a Q3014. I should have that committed to memory, but there's one code for the originating site. Whenever you can bill originating site, one code no matter who you are billing for it, and one payment amount.
All right, thank you for that. Let's see. If the rural designation for originating sites goes back into effect and we have a site that is not defined as either a rural or HIP area, could that urban clinic still serve as an originating site if they don't bill the originating site fee, or will that site be ineligible altogether to host a visit?
Yeah, that's a great question. So the originating site would not bill an originating site fee if we revert to the rural geographic area requirements and a non rural healthcare provider had the patient present to their facility. But also, the distance site professional would not be able to report that service because it doesn't meet the coverage criteria for a telehealth visit to a member with Medicare. What you could do, though, potentially, if it's a benefit your population of individuals with patients with Medicare benefits, like, you could look at using an advanced beneficiary notice and giving the patient advance notice. We think Medicare may not pay for it, or putting like a GA modifier, maybe even a GY modifier. And if they have a supplement that might pick it up, great. And if they don't have any supplemental insurance, that they would be willing to pay the cost for that service that doesn't meet Medicare criteria for coverage and payment.
Right. Looks like our other question is, would this potentially affect billing for things like remote patient monitoring, where modifier 10, a patient's home, is used for billing?
Okay, that's a great question too. Remote patient monitoring and other care management services, they are not technically telehealth under the Medicare program. They have their own benefit category. So telehealth is a benefit category, and care management is a different benefit. So that's a great question, because remote patient monitoring does not today, prior to the PHE or October 1, no matter what happens with Congress, remote patient monitoring does not require that the patient be in a rural geographic area. And because it's not even a face to face service, it's a non face to face service, they don't have to present to an eligible originating site when they're sending that data through the remote patient monitoring device. Great question. RPM, other care designated care management services are not subject to this reversion of telehealth policy that we might see on October 1. Other care management services are things like transitional care management, chronic care management, complex chronic care management. Gosh, we've had so many created in the last couple of years. Behavioral health integration, psychiatric collaborative care, all of those are not quote unquote telehealth benefits under the Medicare program. So this October 1 deadline is not going to change anything for those services.
Great. Thank you so much for that, Rochelle. It does look like we have two more questions. For acute speech therapy consults in a critical access hospital offered by an employed offsite speech therapist, they're wondering what modifier or place of service would be used with the normal CPT code.
Right. So let me think through this. We have a critical access hospital, employed speech therapist. I guess one question might be whether they're method 1 or method 2 billers. So it would kind of be a question of whether it's the speech language pathologist that is the distant site biller, or whether the critical access hospital is the distant site biller. Now, give me what was the where the patient's located at the time of service?
It just says offered by an employed offsite speech therapist, but they're wondering what the modifier or place of service would be for a normal CPT code. And it looks like Andy, who asked the question, said that the critical access hospital is the distant site biller. The patient is then
Okay.
either in a critical access hospital or a skilled nursing facility bed.
Got it. Okay. So the place of service code, if you're billing on a 1500 for that professional service, is 02, excuse me. Um, Skilled nursing facility is not considered the patient's home. But if I change those facts a little bit, and instead of skilled nursing facility, it's an assisted living or independent living facility, that might be the patient's home, that would change place of service from 02 to 10. Then modifiers, if it were audio only, we would have 90, 3 is their non-FQHC, non-RHC as an audio-only service.
It looks like Mandy was
And then
able to give a little bit.
I'm
Sorry.
sorry. I was just we would also double check. I cannot remember, Mandy, who asked the question. I can't remember if speech therapy evaluations, if those CPT codes remained on the list of eligible telehealth services for this year. So we'd also want to check that first too. Even though speech therapists are eligible distant site providers, if CMS took those codes off the list, then you're eligible, but you don't have any services to bill. I think it continued. I saw someone in the chat pop up. I think they did, but I can't remember off the top of my head.
Okay, perfect. It looks like she provided a little bit more input as well, that it was if billing on a UB04, so not billing from a professional aspect, but as an institutional service.
Got it. Then we wouldn't have the place of service 0, 2, and 10 indicators on that claim form, but the service location field, you're going to put the location where the patient, well, hold on. Let me think through that. The service location. I'm going to have to take that question back. I was getting ready to say the skilled nursing facility's address, but the service is being provided from a remote location. So there was some public health emergency guidance on that scenario, and I want to look it up to make sure I get you the right answer.
Yeah, definitely. We will send kind of all of the question answers. You guys have great questions today, so we'll be sure to send those in the follow-up email. We do have one last one I think we can get to, and then if you all have any additional questions afterwards, you can always email those to us. So the last one is the 2023 CAA included an extension through 12/31 of this year for ESRD dialysis facilities, waiving the requirement for the patient to be seen in person at least monthly. They're wondering if you know if this was extended through September 30th of this year.
Yeah, that's a good question. Let me check. I don't remember. There were some other kind of, I don't want to say insignificant, smaller policies like providers being eligible to do home health certifications and hospice certifications via telehealth instead of an in-person visit. So I would imagine that particular flexibility was also extended as kind of a comparable rule. But let me verify that. In-stage renal disease in-person requirement, we will check and get that answer back to you.
Perfect. Thank you so much, everyone, for all your great questions. And thank you so much, Rochelle, for all the great information provided today and all of your answers. I'm trying to see, sorry, I'm having some technical difficulties myself with getting my screen shared. We do have some upcoming events. I'll just talk through those and we'll make sure to send them out with the follow-up email as well. On May 23rd, the Kansas City Diabetes, Obesity, and Nutrition Seminar Series, they'll be hosting Dr. Wendy DeMark-Wanifred, who will be discussing ways to implement stealth interventions to cultivate improvements in lifestyle behaviors and health outcomes. And then on June 4th, HTRC will be hosting Dr. Bradley Anderson and Jared Droz from OSU Medicine to discuss the use of telehealth navigators to promote digital health. As mentioned earlier, we will email the recording and all of these follow-up resources that we've talked about as soon as they've been processed. And again, if you would like a certificate of attendance, please just send that request to our email address that's in the chat. And thank you all so much for joining us today. We look forward to seeing you next time.